My name is Dustin. I am the Communications Director for the Macular Degeneration Association. We are a 501c3 nonprofit, and we are supported completely by donations from people like you, as well as our wonderful sponsors, such as Regeneron, Apellis, Iveric Bio, MacuHealth, and No Television. We also bring these programs to you thanks to our medical board. So we would like to thank all of them for all their continued dedication to the organization. Tonight we have a good program for you discussing dry AMD. Today we are going to be joined by Dr. Eichenbaum. He is on the Macular Degeneration Association's medical board and also serves as Director of Research for Retina and Vitreous Associates and has been principal investigator in over 70 early to late stage clinical trials studying common retinal diseases such as dry and wet macular degeneration, diabetic eye disease, and retinal vascular disease. He has published over 50 articles in professional journals and authorized multiple textbook chapters and continues to passionately contribute to the current retinal literature. We'd now like to turn our attention over to Dr. Eichenbaum.
Hello, welcome. Thank you for attending. I'm grateful that we have a robust audience tonight of folks who want to talk about macular degeneration. I have a relatively short, fairly basic slide deck because I think there'll be people with varying levels of interest and experience with macular degeneration out there. And I'm here mostly to answer your questions. I'm David Eichenbaum, as you heard in that very kind introduction, and I am the Director of Research at Retina Vitreous Associates of Florida and also serve an academic role at the Morsani College of Medicine at the University of South Florida. Today, we're going to talk about macular degeneration, kind of go over a couple of things that everyone ought to know. So how many people in the US have macular degeneration? In 2023, it's more than 20 million people. And of these 15 to 20 million people, more than 3 million have more serious forms of macular degeneration, including geographic atrophy and wet macular degeneration. There are 200,000 new cases a year, so you are not alone. The number of folks who do suffer from advanced macular degeneration is expected to more than double over the next generation, which is why we put so much time into developing better therapies and utilizing the already excellent therapies that we have for this public health problem. So a couple of things we're going to touch on today is what is the macular degeneration diagnosis entail, who's at risk for it, when you should talk to your doctor, things to be educated about, and of course, advancements in treatment. Age-related macular degeneration is a chronic condition of the eye. It is not curable, regardless of the type, wet or dry. Treatable now, but not curable. It requires continuous monitoring and regular treatment, and it is a major cause of central vision loss. It does not blind you, it takes your central vision. If you look at the eye, it kind of works like a camera. The front of the eye is the cornea, that's the sensitive part. That's the part that you irritate when you get your eye scratched, that you put contact lenses on, where they do LASIK. Inside the eye is the lens, where general ophthalmologists do cataract surgery, exchanging the lens on the left side of this picture for a plastic one. In the macula, in the back, you have your sharp central vision, your rods and cones. The macula, which you see on the right side of the image, is part of the retina, which is the film of the camera. The difference between the macula and the rest of the retina is kind of like the difference between Atlanta and Georgia. Atlanta is within Georgia, the macula is within the retina, but the macula has a highly concentrated population of rods and cones and is where you focus your vision to see sharp, clear things. The peripheral retina sees fuzzy images, which is why people with macular diseases only see fuzzy images and have a blurry central vision because their densely populated macula is not well. There are two forms of macular degeneration, dry and wet, and macular degeneration occurs when the macula becomes damaged. Dry macular degeneration is the most common cause of macular degeneration. It occurs when you get deposits under the retina. You see the picture to the right, these little yellow spots, those are drusen. Those are the most typical finding in early to intermediate dry macular degeneration. And this can go unnoticed, although a lot of people, as the drusen accumulate, do develop symptoms. Some people who have dry macular degeneration don't have problems, as I was stating, but some people who have dry macular degeneration do have problems. And there is an advanced form of dry macular degeneration called geographic atrophy that about 10% of people do progress to. It's about the same number of people who progress to advanced wet macular degeneration, which is the other form of advanced macular degeneration. We've been treating wet macular degeneration for over 15 years now. And just this year in 2023, we've started to have some commercially available treatment options for advanced dry macular degeneration. Wet macular degeneration is the kind that we know the most about. It is the most aggressive, fastest moving type of macular degeneration, with about 200,000 new diagnoses per year. And the risk for this is similar to the risk for advancing dry macular degeneration. The risk is comprised of a combination of time or aging, genetics, and for an environmental risk factor, smoking. We know that in wet macular degeneration is an overaccumulation of vascular endothelial growth factor, or VEGF-A. There are other proteins that are implicated in this too, but most of our commercially available drugs exclusively target VEGF-A. Our newest commercially available drug also inhibits a second protein implicated in macular degeneration with leakage called angiopoietin-2. The symptoms of advancing macular degeneration, whether it's wet or dry, is increased distortion and a fuzzy or blurry spot in the center part of the vision, like you see in the picture on the side. The Amsler grid is a great tool. I'm sure many people on this call are experienced with Amsler grids, but it's not the only tool. There are also other things you can use, like windowsills, door frames, other things you can use to see what the impact is on the central vision of macular degeneration. You can check these other things or an Amsler grid to see if you're having rapidly changing disease. Rapidly changing disease is indicative of a conversion to wet macular degeneration. If you have advanced macular degeneration in one eye, the other eye is at risk. People who have advanced degeneration in one eye, whether it's neovascular wet degeneration or geographic atrophy, have a high risk of loss in the other eye, so continue to check both eyes. And like we talked about, the risk factors have modifiable and non-modifiable components. The non-modifiable components are the passage of time and the genetics, the family history. There's a correlation with macular degeneration with females and with Caucasians. Modifiable risk factors include smoking, hypertension, obesity, and low levels of nutrients. The most striking environmental correlation and the most impactful one is smoking. Vitamins, micronutrients probably do reduce the risk of progressing to wet macular degeneration. The age-related eye disease study, or ARED study, looked at these, and a combination of beta-carotene, C, E, zinc, and copper may reduce the risk of developing advanced macular degeneration of the wet type. And that's available commercially as AREDS vitamins and through a whole bunch of brand names too. Brands are not important with the vitamins, the components are. And as long as your components say AREDS or AREDS2 on them, that's the components that you need. Diets rich in leafy green vegetables are correlated with a reduction in population's rates of macular degenerative disease, so eat your colors. And know your eye team. It's very important to start with basic eye exams. I'm a vitreoretinal specialist. Most people don't need a vitreoretinal specialist. I certainly depend on my general eye doctors, my general eye care providers like optometry to examine patients and assess them for macular diseases and detect macular disease early on. Ophthalmologists are medical doctors who specialize in the eye. They also do procedures like cataract surgery or other laser surgeries, which optometrists do not typically do. Ophthalmologists also provide comprehensive eye care. Retina specialists are ophthalmologists like me, folks who have additional training in diseases of the macula, vitreous, and retina, and we do typically treat wet macular degeneration and dry macular degeneration. Tests you can expect. The eye chart is kind of our gold standard. This is the speedometer of the eye. We always want you to read letters. The Amsler grid is something we'll check in the office and something that you check at home to look for changes in macular function. dilated eye exams are necessary. Maybe not every time you come to the ophthalmologist's office or the retina specialist's office, but certainly some of the time. We do want to dilate your eye periodically and look inside. Imaging tests are something we lean on all the time in retina. We lean on fluorescein angiography, which is an old imaging test using a fluorescent dye. OCT is probably the most commonly performed imaging test in the retina space, where we look at the macula using a cross-sectional scan created with laser interferometry from a camera that we have in our offices, which looks at changes in macular anatomy and allows us to quantize them, which is pretty important. Treatments for advanced AMD exist. Treatment is almost always an injection into the eye in the modern era. That is by far the most common treatment. It's superior to older laser treatments for macular degenerative disease. The eye is always numbed. There's a lot of ways to numb the eye. If there are questions about the injections and how to make them more comfortable, I'm happy to address those. There are multiple commercially available drugs for wet macular degeneration, including Eylea, Vabysmo, Lucentis, and Avastin. They go by, those are the brand names. They also have pharmacologic names to them: aflibercept, faricimab, ranibizumab, and bevacizumab. And we have a commercially available drug for dry macular degeneration called Syfovre. It's specifically for patients with geographic atrophy. Its scientific name is pegcetacoplan, and it inhibits a complement factor. What is a complement factor? A complement factor is an inflammatory factor, and the Syfovre works against that inflammatory pathway to modulate it in folks with geographic atrophy. After an injection, your eye is typically a little red. However, it should improve rapidly. Even if it doesn't look completely normal the day after an injection, your eye should be painless the day after an injection. Irritation and a foreign body sensation and some burning are all normal things on the day of injection. It should be much better the day after. I tell all my patients to go home, have a whiskey or a wine, and take a nap, and your eye will feel a lot better. If you do ever get an injection and your eye feels worse a day or 2 or 3 afterwards, call your doctor. Don't tough it out. We worry about infections with these injections. They're very, very rare. 1 in several thousand injections, but that's what we're looking for. We ask you to call us if things get worse. What do visual acuity scores mean for visual function? Well, if you have near normal vision, which is 20/30 to 20/60, this means that you don't see normally, but you may have difficulty reading, trouble reading small print, trouble reading the newspaper, things like that. And sometimes you can benefit from lighting and handheld magnifiers with nearly normal vision, 20/30 to 20/60. 20/60 to 21/80 is moderate vision loss, and there's often difficulty reading even large print materials, even with a magnifier with this level of vision. This is where you begin to rely on prescriptive low vision aids. Severe low vision is 2200 to 2400. This is an extreme level of difficulty with regards to recognizing people's faces following road signs and things like that. And this relies on prescriptive low vision optical and electronic devices to at least read. What are the tips for living with low vision? Well, avoid driving at night or in bad weather, or really walking around and doing things that are low contrast, because contrast sensitivity, meaning like gray skies, movie theaters, dark restaurants, are hard on people with macular degenerative disease. Travel with loved ones. Be sure you have the very best glasses. Use magnifiers. Use light. Bring the room lights up. That'll help you see better when you have macular disease. And lastly, develop a relationship with a low vision optometrist. You've often got a low vision optometrist in almost every developed market in the United States. Things you can do and things you can use to help see better include large print books, large print bills at home, as I said, special lighting, and visit your ophthalmologist or retina specialist or general optometrist on a regular basis. Talk about how things are progressing in the world of geographic atrophy and untreatable macular degeneration. That's my whole talk. I have about 30 minutes for Q&A, and I'm happy to entertain whatever the audience would like to discuss. That covered a whole range of basic general health topics, basic macular degenerative topics. I'm sure there are questions out there regarding what we're seeing in dry macular degeneration, which I touched on, but we can talk about whatever comes to mind. The first question is, do eye drops help? And that's a great question. Eye drops do generally help eyes that are dry or eyes that have allergies or eyes that have blepharitis or irritation. They do not help age-related macular degeneration. There are drops that are undergoing clinical trials, and there have been drops for years undergoing clinical trials that would be prescriptive that may help macular degeneration or at least reduce the number of injections you need in macular degeneration. None of those have shown efficacy at this point. But eye drops, like over-the-counter lubricating drops, do help with eye comfort, but they do not help with macular health. Okay, this is a huge question. A couple more questions coming in. Could you discuss Syfovre in more detail, and at what point is macular degeneration, dry macular degeneration, treatable with the first commercially available drug for dry macular degeneration, which is Syfovre? So let's talk about Syfovre some, and please do keep the Syfovre questions going as I talk about some. So what is Syfovre? Syfovre is a brand new, not brand new, it was approved in February and commercially available in March. It's a new injectable medication which is approved for dry macular degeneration with geographic atrophy. It is injected between every 1 and 2 months, and unlike the drugs for wet macular degeneration, this drug for dry macular degeneration does not have a period where it makes vision better. Syfovre reduces the rate of growth of the dry macular degenerative spots if it's initiated and adhered to for every 4 to 8 weeks. We just saw at the American Society of Retina Specialists last week the first set of extension data on it, which goes out to 30 months. And there does seem to be an increase in the effect over time, as in a greater reduction of the growth of the advanced dry macular degeneration, the geographic atrophy, for patients who start and stay on Syfovre. Like any other drug, it does have risks. There's a risk of infection with any of the eye injections. There's a risk of inflammation with any of the eye injections. We're looking at a couple of cases with the Syfovre that had inflammation associated with them, but it's a very safe and well-tolerated drug, FDA approved in a study of 1,200 patients who received over 23,000 injections. We're learning a lot about it, Syfovre, together as a community and with our patients, and with other retina specialists who are involved in clinical development and involved in dry macular degeneration drugs. And there are other drugs to come that hopefully will be even more effective and have to be administered less frequently than Syfovre. Whole bunch of questions coming. I'm going to try to hit more of the Syfovre stuff. Here's a question. Many retina specialists in my county do Syfovre injections, but none will do this for Medicare Advantage patients. How do we get coverage? It's a great question. So Medicare Advantage is a type of insurance coverage where beneficiaries give up their Medicare. They trade in their Medicare for Medicare Advantage plans, which are managed care plans and much more restrictive. It's like having a commercial insurance plan, even though you're a Medicare beneficiary, but you've traded in your Medicare benefits for Medicare Advantage. You have to write your plan's administrator and ask your plan's administrator if they will release a coverage decision for any drug that you want. If that drug is Syfovre or what have you. Medicare Advantage plans are for profit, and there's more profit if they restrict access to costly medications. So everyone needs to write letters. We write letters as the American Society of Retina Specialists on behalf of patients. Open enrollment is coming. I encourage folks who want access to branded medications to depart from Medicare Advantage plans, join original Medicare if they're of Medicare age, and purchase a Medicare supplement. That's what my mother does. She's 82. She has original Medicare with an AARP supplement. And that's the best way to get coverage, I think. How is Syfovre given and how frequent is the injection? I have one eye with wet AMD, one eye with dry AMD. Can it be given on the same day? Syfovre is given every 1 to 2 months. It's approved for every 1 to 2 months. It was studied every 1 to 2 months in the registration trial, which now has 30 months of total data. If you have one eye with wet AMD and one eye with dry AMD with geographic atrophy, and if you and your doctor decide together that Syfovre has an appropriate risk and benefit balance for your eye with dry macular degeneration, can you get these drugs on the same day? That's between you and your doctor. I do a lot of same-day bilateral injections. Otherwise, patients are coming all the time. It's a lot of time. You got other things to do than come and see me. I think same-day bilateral injections are definitely reasonable. I would discourage patients from driving after same-day bilateral injections to their doctor's offices. Certainly an option, certainly something to talk to your doctor about. Let's see. What else about Syfovre do we have so far? Is there a billing J code for Medicare for Syfovre? There is not. It's called an unlisted J code right now, which does make it harder to get reimbursed for it. It depends on whether or not where you live in the country with regards to whether or not your Medicare carrier is paying for Syfovre now for your retina specialists. There will be a J code for it, usually about 6 to 12 months after approval, so probably by the end of the year or early next year. Let's see. Can this drug work for geographic atrophy if you also have wet macular degeneration? It's a great question. So all of the patients who came into the registration trials for Syfovre, as well as most dry macular degeneration drugs, have pure dry macular degeneration with geographic atrophy in the eyes that were treated. So we know a lot about eyes that are pure geographic atrophy eyes. Does the drug also work if you have wet AMD? Well, some of the patients in the studies for dry macular degeneration did develop wet macular degeneration. There actually seems to be a slightly higher proportion of patients who do develop wet macular degeneration when they're treated with Syfovre or other drugs for dry macular degeneration. Those patients in the study were treated for both, and they seem to do well. We don't know exactly how the drug works in patients who have years of wet macular degeneration and then have progressive atrophy that looks like geographic atrophy. That population of patients has not been studied, but that population of patients can be treated, and we can think about whether or not that's reasonable to offer patients who have long-standing wet macular degeneration and some dry macular degeneration with geographic. Don't have a ton of evidence on that population. My impression of the data is that if you have a patient you've known for years and they have wet macular degeneration and they also have spots of dry degeneration that are progressing in a fashion like geographic atrophy, then the drug could work in that patient. It's certainly something that I've talked to patients about. But most of my patients on Syfovre are patients with pure geographic atrophy. Let's see what else we have on Syfovre. Can Syfovre be used for dry macular degeneration besides the advanced type with geographic atrophy? Another excellent question that has not been studied in earlier stages of dry macular degeneration. It's not approved for that, and it has not been studied in that stage, and I would not recommend Syfovre for patients without geographic atrophy with earlier intermediate dry macular degeneration. There is risk to the injections. We don't know if there's any benefit in that group of patients. I certainly wouldn't recommend that. Let's see. More stuff about dry degeneration and Syfovre. A little bit more about geographic atrophy and more symptoms and causes. Causes are fairly well defined as genetics, time, and for environmental causes, it's smoking. the most common symptoms of geographic atrophy are advancement of central vision loss, like we saw in the presentation. When you have advancement of central vision loss, difficulty reading, distorted spots, missing spots in the vision, those are symptoms of advancing macular degeneration. It's hard from the symptoms to tell necessarily if it's dry or wet. If the symptoms progress quickly, it's more likely to be wet. All right. I was advised not to use Vabysmo or Syfovre because I have wet and dry in both eyes and geographic atrophy in one eye. My doctors feel that the risk for another bleed is not worth the risk of the injections. What's your opinion? I've been receiving acupuncture, which has kept my inflammation in check. My eyes have been stable. One eye is 20/40. That's a confusing question to me. I think if there's active wet degeneration, then maybe treating that would be reasonable. If there's dry macular degeneration with geographic atrophy, Syfovre certainly worth considering. I don't know a ton about acupuncture. I have no problem with holistic treatments, acupuncture, whatever patients choose to have. I think the risk of harm for those things is low and there may be some benefit. So if that's working for you, you should keep it up. I think that's fair. Let's see. Can you lose all of your vision with geographic atrophy? Excellent question, something that people are very fearful of. No, you lose your central vision to geographic atrophy or to wet macular degeneration. You never go blind like the lights go out. The peripheral vision always persists in geographic atrophy, but you lose your functional central vision. Let's see, other topics that we have. I think we hit most of the Syfovre questions. So let's do other topics. We have lots of general topics. Oh, how do we know when we have geographic atrophy? It's a diagnosis that has to be made, usually with an exam and concurrent imaging from an optometrist, ophthalmologist, or retina specialist. Then you know if you have geographic atrophy. It's not something you can detect on your own. It is almost always accompanied by some degree of vision loss. And then I have dry macular degeneration. How do I know if I need the dry macular degeneration medication? Do I have the atrophy part? Again, a very similar question. And the best answer is go see your doctor and write those questions down beforehand and talk to them about it. If your doctor can't answer those questions, definitely get an opinion from another doctor who can answer them. Any of your eye care providers, optometry, ophthalmology, or retina, should be able to tell you if you have geographic atrophy, and then you can talk to them about whether or not you're a candidate to consider Syfovre, whether the risks and benefits balance in your favor. And if they're not someone who works with Syfovre directly, they can often refer you to a retina specialist who does. What are the chances of developing wet macular degeneration after taking Syfovre? Another very good and very important question. So the Syfovre clinical trials were divided into 3 different groups. There was a group that received no treatment called sham. There was a group that received treatment with Syfovre once a month, and there was a group that received treatment with Syfovre every other month. The group that received sham, that received no Syfovre, had the lowest chance of developing macular degeneration of the wet type. When you start being exposed to Syfovre, the risk of developing wet macular degeneration increases. It increased from about 1 or 2% in the patients who did not receive any Syfovre for the 2 years of the trial, 24 months to the end of the study, the initial study before extension. When patients received Syfovre every other month, that risk doubled to about 3 or 4%. And then when patients received Syfovre every month, that risk doubled again to about 6 or 8%. So the risk of developing wet macular degeneration increases when patients are exposed to Syfovre. The Syfovre patients who did develop wet degeneration generally did stay in the trial and did do well with treatment for the wet degeneration as well. But like everything else with therapeutics, there is no free lunch, there is no riskless medication, and there is an increased risk of wet when patients are using Syfovre. Let's see what else we have here. What are the differences between dry macular degeneration and geographic atrophy? It's another good question. Geographic atrophy is a form of dry macular degeneration. The difference is geographic atrophy has these characteristic appearances where patches of the macula, like patches of a map, are missing. That's why it's called geographic, because it looks like a map. It looks like a map of the US where states have been pulled out. And that's why we call it geographic atrophy. And the difference is it usually is more sight threatening. For dry macular degeneration and geographic atrophy, how much zinc will benefit per day and how much zinc is too much? I think that the dose of zinc that has the most evidence is the dose used in the age-related eye disease studies. I don't think there's necessarily any published benefit of using more than you see in an AREDS vitamin. So I would definitely stick with the AREDS vitamins. Here's a great question. My retinologist told me there have been too many side effects for him to recommend the approved drug, which is Syfovre. Your thoughts? So your retinologist is very smart to think about the risks of a drug as well as the potential benefits. This is the first generation drug that we have for dry macular degeneration. There have been cases of inflammation, there have been cases of infection. Just like with any of the other injections, we're learning more about the cases of inflammation that we've seen, which have been rare. There have been 8 or so reported, perhaps up to 11, and about 83,000 distributed injections so far. Is the risk worth the benefit? That depends on the level of geographic atrophy you have, the level of engagement your retina specialist has with the data, and your conversation that you have with your retina specialist. And it really depends on everyone's comfort level with risk and everyone's understanding of the benefit. And that's a very individual conversation. That's certainly a conversation that can go on with your retina specialist, since geographic atrophy is a relatively slow-moving disease. Not slow-moving, it does progress, but compared to wet macular degeneration, it's relatively slow-moving. And it's a conversation you can have over a couple of months with your retina specialist. There's no pressure to start Syfovre promptly. Like when you have wet degeneration, there is some pressure to start treatment promptly, because if you don't start treatment with wet degeneration promptly, over a couple of weeks, you have permanent vision loss. With Syfovre or dry degeneration with geographic atrophy, you don't develop permanent vision loss quickly. Okay, let's go to some non-Syfovre questions, because we have a whole bunch of those too. Regarding drusen, is that a warning sign that macular degeneration is in your future? Well, drusen are definitely one of the earliest signs of developing macular degenerative disease. And the larger the drusen, the more numerous the drusen, the greater your risk. The presence of drusen alone, especially at a young age, a pre-macular degenerative age, does not necessarily confer much risk. But as you get older, if your drusen accumulate, that does increase your risk of developing more advanced forms of macular degeneration. My mom is 101 and was diagnosed with dry macular degeneration. At that point, is there something for her to do? She is very active. Certainly, if your mother has a treatable form of dry macular degeneration, especially if it's the more rapidly progressive wet form, the benefits of treatment probably outweigh the risks. If she doesn't have wet degeneration or geographic atrophy, she can probably just take vitamins and do the best she can with her pretty good vision. All right. Are colors more difficult to discern in macular degeneration? Excellent question. Yes, color saturation does become more difficult in patients with macular degeneration, even of the mild to intermediate type. The thing you can do to improve color saturation is use brighter lights, use higher contrast colors that are more saturated. And that generally does help, but you cannot restore normal color vision even with treatment. Does removing cataracts help, or just let in more light? Removing cataracts certainly does let in more light and usually does improve acuity if the cataracts are dense and visually significant. Patients who have advanced macular degeneration never have normal vision after cataract surgery because there's additional diagnoses going on. It's like if you change the lens in the camera, but the film is still a little raggedy, you'll still have a little bit of a raggedy picture. But taking out the cataracts often does improve color saturation, improves contrast vision, and sometimes improves acuity, even with advanced macular degeneration. Should I have antibiotic drops following my eye injections? That's a decision that you and your doctor can make. There's something we call the Preferences and Trends Survey that the American Society of Retina Specialists administered, and the preferences and trends show that most retina specialists do not prescribe antibiotic drops after intravitreal injections, but some do. Can drusen be prevented? It's hard to prevent drusen. It's like preventing wrinkles. You kind of got to die young. That's tough, or have really good genes and live a long time. So the short answer is no. Don't prevent the drusen. Live well, take care of your bodies, and let the drusen be. Hope for the best. Individual patient question. My last eye injection for wet macular degeneration rendered my eye blurry for about 5 days. Is this normal? I did go back for a check and my doctor did not find any issues. You can and usually do have blurry vision after injections. It is usually not for 5 days. If you receive blurry vision, if you experience blurry vision or decreasing vision after any eye injection, always go back for a check. That's exactly the right thing to do. I think that using an eye drop or asking your eye doctor if there's a prescription drop that can help, if there's repeated kind of long term blurry vision after injections, I think using an eye drop or a prescription drop might be helpful if you're blurry for several days after repeated injections. Certainly a conversation to have with your treating doctor. Is there research looking at biochemical analysis and epigenetics over injectables? Another excellent question. There's a lot of retinal research, a huge pipeline funded almost exclusively by pharma, looking at epigenetics, looking at biochemistry, looking at really people's innate genetics, usually in concert with an active therapeutic. But we're taking a lot of time and making a big investment in assessing people's genetics to see if treatment can be individualized. So the short answer is yes. Is there a stem cell treatment available that will be more effective at reversing vision loss? Well, there is not an available commercially approved stem cell treatment anywhere in the world for dry macular degeneration or for wet macular degeneration, but really it's better suited to dry is what we think. There is pipeline for regenerative therapy looking at stem cells. There have been small series published in humans. There have been clinical trials in humans in small groups with stem cells, and they do show incredible promise, which is awesome. There is also some significant risk to the stem cells. They're dividing cells. There is a risk of giving people a mutagenic tissue that could generate a cancer. There's a risk of causing intractable retinal detachments that can never be repaired. There's risks of epiretinal membranes. We've seen some of those risks play out in the small series of human trials. So it's not a therapy that competes safety-wise with other therapies at this point, but we're encouraged and looking forward to developing safe and effective stem cell therapies. I think that the timeline for that, at least for the timeline for the drugs to get into larger phase 2 trials, is probably on the order of 2 to 5 years, I would say. And if those trials go well, they'll advance. If they don't go well, we got to go back to the drawing board. And it's going to take some time, but there's a lot of excitement about regenerative therapy. Last question I have, right on time pretty much, and thank you again for asking so many questions. I thought that would be a robust part of our program tonight. Is we have 2 more questions now. Good. So if you have any questions, get them in. We have about 4 minutes left until Dr. Blemker can come on. You guys don't know how lucky you are to have Dr. Blemker. I've collaborated with her, I've talked with her many times, and she's very, very smart. So you're going to have a fantastic talk with her. I've been diagnosed with geographic atrophy and I'm losing my sight quickly. Should I try the Syfovre shot? What if I would like to join a study? Will doing the treatment keep me from being accepted? So it's a really good question. The Syfovre shot generally is exclusive from enrolling studies right now, but I think the protocols will change because a lot of patients are trying Syfovre. If you live in an area where you have a practice that does both regular retina clinic and clinical trials, like our practice in Tampa Bay, talk to that practice and ask the doctors there, who are often either principal investigators or sub-investigators in the clinical trials, if you'd be better suited to Syfovre treatment or enrolling in a clinical trial, because both are probably currently an option if you haven't started the Syfovre treatment. But if you're motivated and you have a clinical trial site in your geography, I would go to that practice specifically with the appointment to talk about clinical trials versus Syfovre. Then you can think about it and make a choice to see whether or not one, the other, or neither is correct for you at this point. But you got to go somewhere that does trials. If you're going to have a talk about trials, if you go to a practice that doesn't do trials and they just do Syfovre, that's the option you're going to be offered. Is eye color a risk of macular degeneration, e.g. is blue more likely to get macular degeneration than brown? So lightly pigmented people, like Caucasians, are definitely a population which is more likely to develop traditional macular degeneration. Light colored eyes are probably part of that risk factor spectrum, and people with light colored eyes probably do have a higher risk of developing macular degeneration than folks with darker colored eyes. But that's because the light colored eyes are kind of a reflection of the pigmentation in the back of the eye too. If you look inside an eye, like in an operating room, like I was in the OR this morning, looking inside an eye with a retinal detachment, the darker colored irises have darker colored tissue inside the eyes and darker colored skin and hair and nails and all that usually associated with them. And there's something protective about pigment with regards to progressive macular degeneration. In the stem cell study, do people use their own stem cells? No, I think most stem cell trials, or all stem cell trials, have been with pluripotent stem cells, which are human embryonic derived stem cells from cell lines. So thank you, everyone, for being a fabulous audience and asking fabulous questions. I really like this format. It's very important to end on time, and I'm doing exactly that, turning the program back over to Dustin to introduce Megan Blemker. Always wear your sunglasses, always eat your colors, always exercise and quit smoking. Throw out those cigarettes. I'm David Eichenbaum from Retina Vitreous Associates of Florida and Tampa Bay, Director of Research. Happy to be here, grateful to take your questions, and thank you again to the Macular Degeneration Association for this opportunity.
Thank you so much, Dr. Eichenbaum. It was great to have you. Thank you for covering this really cutting edge article or information for us. We know that it's not brand new, but it is still on the newer side, so people have a lot of questions, so we appreciate you coming on. Now we'd like to introduce Dr. Blemker. Dr. Blemker is an ocular disease residency trained optometrist who practiced in Nashville, Tennessee area for 9 years before transitioning to industry. She was an executive clinical outcome specialist with Bausch & Lomb Surgical for 4 years prior to joining the Notel Vision team a little over 5 years ago, where she serves as Director of Clinical Affairs and Education. Dr. Blemker, you have our attention.
Thank you so much for the introduction. Notel Vision is proud to partner with the Macular Degeneration Association, and I appreciate the opportunity to speak to you all today. It is such a privilege. To reiterate some of the important points made in the presentation, I would like to further discuss understanding the importance of early detection of wet AMD and how you can play a role in protecting your vision. 4C Home is FDA cleared and Medicare covered, and prescribed by your eye care professional when appropriate level of vision and stage of AMD. It is a form of personalized medicine with the 4C Home device used at home in between your regular eye exams. It detects metamorphopsia, or visual distortions, in AMD. AMD, or age-related macular degeneration, is the leading cause of severe central vision loss in people over the age of 50 years in the United States. I'm going to share with you the information you need to get informed and take charge of your vision. AMD is a chronic, meaning it does not resolve or go away, progressive, meaning that it tends to worsen over time, type of condition. And there are 2 types of AMD, dry and wet. Dry AMD is the slower changing, earlier form of the disease that puts you at risk for developing wet AMD. Wet AMD is the sudden change or advanced form of the disease. AMD affects an area of the retina called the macula, which is responsible for detailed central vision used for activities like reading, driving, and seeing faces clearly. In dry AMD, changes occur in the cells of the macula, and drusen, or deposits, build up in this area. These changes may induce blurry vision, such as difficulty seeing sharp details, both up close and from a distance. Dry AMD is the slow form of the disease with changes you may not even notice over time. Most importantly, dry AMD puts you at an increased risk of progressing to wet AMD. Over time, the size and number of these deposits can increase, which increases your risk of developing the more sight-threatening form, wet AMD. Again, dry AMD can suddenly change to wet AMD without any advance notice. If you convert to wet AMD, abnormal blood vessels grow under and into the retina in the macula. These blood vessels leak fluid and can sometimes bleed without any warning. You may not notice changes until significant vision loss has occurred. If you convert to wet AMD, significant vision loss can be rapid and severe. Symptoms of wet AMD include distortion, or straight lines that look wavy, and dark spots in the center of your vision, or generalized blurry vision, as you see here on the screen. Unlike dry AMD, there are effective treatments for wet AMD, but these treatments are most effective when administered early on before symptoms are noticed and vision loss has occurred. These treatments can halt or slow the progression of wet AMD, but they cannot restore vision that has already been lost. Once the wet disease starts, it will continue to advance until you receive treatment. Irreversible damage can occur within days to weeks and before symptoms are noticed. But how early is early detection? Once symptoms of visual impairment are noticed, those wavy lines or dark spots appear, then vision loss may have already occurred. The earlier you catch wet AMD, the better chance you have of preserving your vision and your independence. So, wet AMD treatments are most effective when the disease is caught early. 4C Home is an early warning system for your eyes. You use this device at home in between your regular eye exams. It helps people with dry AMD detect wet AMD before you even notice that visual changes have occurred. But how does it work? Well, you take a simple daily test that checks for tiny changes in your vision, and this test takes just a few minutes per eye per day. Data from each test is sent to your eye doctor as well as the No-Tal Vision Monitoring Center, the medical provider of 4C Home. If a change in test scores is detected, the monitoring center alerts your doctor. Your doctor's office will then contact you directly to schedule a follow-up visit. The AMSR grid was developed in the 1940s and has long been recommended as a simple and accessible tool you can use from home to monitor for changes in your vision. However, by the time you notice vision distortions on the AMSR grid, significant vision loss may have already occurred. Fortunately, new technology, such as the 4C Home AMD monitoring program, has been developed to detect tiny changes before symptoms are noticed and reports them to your doctor so you can receive immediate examination and treatment. Testing with 4C Home is easy. You turn on the device and look into the viewfinder to begin testing. A bump will briefly appear and then disappear. Use the mouse provided to click where the bump appeared and return to the center dot. Data from each test is sent to the No-Tal Vision Monitoring Center for evaluation and then provided to your eye doctor. Regular at-home monitoring is like brushing your teeth. It's a good, healthy habit you do every day to help preserve your vision. 4C Home allows you to take a proactive approach to protecting your vision. A clinical partner will be with you every step of the way. After the No-Tal Vision Monitoring Center receives a referral form from your doctor, we will answer any questions, verify coverage, and ship your device. Once you receive the device, the No-Tal Vision Monitoring Center will walk you through setup and training. You and your doctor will continue to receive feedback from the No-Tal Vision Monitoring Center. Our team will be sure to verify your insurance benefits and discuss with you prior to your acceptance of the device and getting started with the program. There are low out-of-pocket costs for Medicare patients. Patients with Medicare and a secondary supplement plan could have out-of-pocket costs as low as $0 per month. Patients with Medicare and no secondary supplement plan will pay around $15 per month once their yearly Medicare fee-for-service Part B deductible is met. Your doctor will send our No Television Monitoring Center the referral order for you to begin the 4C Home AMD monitoring program. Appropriate candidates have a particular stage of dry AMD and vision level, which are determined by your doctor. You will continue to test regularly at home. If a change takes place, your doctor will be alerted and have you come in for examination. In summary, the No Television Monitoring Center works with your doctor to remotely monitor your dry AMD, helping you retain functional vision throughout your AMD journey. Happy to answer any questions you might have. Thank you so much. Okay, we'll see what questions are popping up in the Q&A. Thanks so much for your time and attention. It looks like we do have a few so far. The first one is, how easy is it to do the test? Well, with the setup for 4C Home, as you could probably tell from the image of the device, there's a viewer that's there that is adjustable. So once you get it set up on the table, it's about 3.5 pounds and about as big as a standard size coffee maker, I would say. But the viewer is adjustable so that your neck and shoulders are comfortable when you're taking the test. And then you'll place your hand on the mouse that is connected to 4C Home, and you'll click with your index finger as you are seeing those lines with the bump or line with the wave that are presented throughout the test. And the nice thing about getting set up with this monitoring service is that one of our clinical partners will be with you as your teammate every step of the way. When you receive the device, if you are a good candidate and you have decided to move forward with the program, then they'll make sure they walk you through setup over the phone, and they'll actually help perform the very first test with you that initial time that you are working with the technology and you're trying to establish your baseline or your starting point. So just know that you will have help and you'll have a lot of support as you are learning to work with the test. Make sure you're comfortable and that you're successful. The next question is, can I only get this from my doctor? Wonderful question. Yes, this is prescribed by your eye care professional. So we will receive the referral form, the information from your doctor that shows you have an appropriate level of vision and that you have an appropriate stage of age-related macular degeneration. I was just listening as Dr. Eichenbaum was presenting. He's so knowledgeable and such an engaging speaker. It was a real treat to have him on today, and a real treat for you all to be able to listen to his presentation, ask him questions. But as he was talking about the different stages of the disease of age-related macular degeneration, there are early, intermediate, and advanced dry or advanced wet stages. And so for 4C Home, it was approved for and indicated for that intermediate stage. So your doctor, your optometrist, ophthalmologist, or your retina specialist would be able to decide if you have that level of vision and that appropriate stage of AMD. Can someone that has shaky hands use this? This is a great point that you bring up. Not everyone is compatible with 4C Home. Most people are. But if you happen to have a tremor or if you have a shaky hand, as was asked in the question, then you may have some trouble with 4C Home. The good news is that our monitoring center takes care of shipping the device to you. And then if you are not compatible after giving it a try, we'll take care of the shipment back to our monitoring center. So there's no obligation, there's no contract, so to speak. You can certainly give it an attempt, and if it doesn't work out for you, then we'll take the device back. The next one says, my doctor doesn't have this. How can I get him to participate? Well, we would love for your doctor to participate. And if you are an appropriate candidate, get you started on the service. I would say go back to your doctor at your next appointment and let them know you have participated in this program and you learned a lot about 4C Home. We also have a website, 4chome.com. On the Macular Degeneration Association website, macularhope.org, there's information about 4C Home as well. If your doctor is interested in any clinical information, they can locate that on the website, or they can reach out to me if they have any clinical questions. Would be happy to provide them information about all the studies that we've performed and how effective it is, or if they have questions on how to get started with referring patients. The next question, are there false findings? Another great question. So in short, yes, every device or technology is designed so that it's very sensitive because we don't want to miss any potential disease or a change in condition or change in disease. So sometimes this will happen in the form of what we call false positives. So if there happens to be an alert or a statistically significant change in your distortion or your metamorphopsia maps with 4C home, then your doctor will receive notification that there's been a change in your testing. They'll bring you in for an examination, and then they will have the chance to evaluate you to see what's going on. And a lot can happen in the macula, in that central portion in the back of your eye. But it's one of those we'd rather be safe than sorry. Another thing to note is that because this is, as we've mentioned, a chronic progressive condition, that it's very dynamic. Things can change over time. So sometimes those drusen can shift, or you can have changes even within the same stage of the disease, but it's up to your doctor as the expert to be able to bring you in for that examination, do the imaging, take a look in the back of your eye, and see what, if anything, has changed. The next one says, I have dry and with GA that experienced a significant change in about 3 months. Does that indicate I am progressing to wet and at this time? As Dr. Eichenbaum stated, I think the best answer to this question is talk to your doctor about this. I thought it was a wonderful suggestion he had about writing down your questions when you go in to talk to your eye doctor, especially after everything that you've learned today, talking about the latest and greatest with medications. They, of course, would be able to evaluate how you're doing now and how you've been doing over time. But if you are noticing changes in your vision, then that's definitely something you should bring up. If you're noticing changes in your vision that have occurred, even since your last exam, that's out of the norm or out of what you're used to seeing, I would prompt you to call your doctor and see if you need to come in sooner for an examination. Again, it's always better to ask or go in for an appointment. Again, better to be safe than sorry. And the last question I have here is, if I have wet in one eye and dry in the other, can I use this? An excellent point to bring up. So if you have already converted to the wet kind of age-related macular degeneration in your first eye, let's say, and you want to protect the other eye, that's a wonderful idea because the fellow eye or the second or the other eye is at a higher risk of conversion to wet AMD once the first one has converted. So again, if your dry AMD eye meets the category requirements with your vision and the stage, then this would be potentially a great idea for you to use 4C home to protect that second eye or that fellow eye. Next one says, I have Blue Cross Medicare Advantage. What are the costs each year before a person reaches the deductible compared to after the deductible is met? I am the first to say that our monitoring center team are the experts. We actually have a patient financial services department that would be able to look at your specific program to see what, if anything, that you would have to pay. We'd make sure that you know those costs and that we've reviewed it with you before we ever ship you the device, before you agree to move forward with the program. I would say in a general, just a blanket statement, as far as the dollar amounts, just on a national level, are if you have traditional Medicare and a supplement that covers this, then you might not have to pay anything each month for the monthly monitoring service. If you have traditional Medicare and a secondary that does not pick it up, then that other 20% averages out to about $15 per month, 15. If you have no help at all with your insurance or you're paying out of pocket, so to speak, it's about $77 per month. But again, this majority of our patients, they pay little to nothing. Again, we go through this before we ever ship you the device. And if there is a concern about the monthly payments, then we have programs to be able to support from a financial perspective as well. So we're going to exhaust all effort to make sure that this is an affordable option. We want all of our patients who are good candidates to have this service. We feel so strongly that it's the best tool in your toolbox, in addition to what your doctor's already doing for your AMD care. And we want to make sure that if you have access to it, we'll do everything in our power, work with your insurance companies and your doctor to see if we can make this possible for you. The next question is, does Kaiser and Northern California participate in this? We do have patients in California. We are able to provide service with the remote nature, of course, of the technology. We're able to ship and provide service all over the country. In particular with Kaiser, again, I would refer you to our patient financial services team, who would definitely be able to give you more specifics. Certainly don't want to speak out of turn, but those general statements I made about the finances or maybe what you can expect to pay would apply there potentially as well. I think the questions are wrapping up. Oh, we've got one more. Let's see. What resources such as journals or magazines or websites would be useful to people with dry macular degeneration who do not have medical expertise? Well, I think you've taken a great first step by participating in this webinar today. Of course, we are very proud to partner with the Macular Degeneration Association. They have ongoing presentations such as this. There is a lot of great information about the latest and greatest in regards to eye care, of course, AMD care on their website. On our website as well, the 4chome.com, we have a lot of information about age-related macular degeneration. We have clinical studies and information, of course, about our 4C Home technology. But as far as these resources, I think you've taken a great first step. The next question is, what makes a good candidate for 4C Home? So if you have that 20/60 level of vision, I know we throw around the numbers when we're talking about visual acuity. As a rough estimate or kind of a set the bar, if you will, level of driving vision in most states throughout the United States is required of about 20/40. So the smaller the number on the bottom, so 20/40, 20/20, 20/60, the lower the number, the better the vision. So if you have 20/60, 60 level of vision or better, it can be better than that, and you have that intermediate or that moderate stage of dry age-related macular degeneration, then you could be a good candidate for this. Of course, it is up to your doctor to determine those two factors, and those could be questions you could ask them the next time you go in. What's my level of visual acuity, best corrected, and then at what stage of age-related macular degeneration am I in?
Thank you so much, Dr. Blemper. We really appreciate you coming on for this.
Well, thank you for having me. It's always a pleasure.
And just as a reminder to everyone, we appreciate you coming on this evening. We just want to remind you that we do have several other programs virtually this year, as well as a few more in person. So please be sure to check our website, macularhope.org, with all the information available to you there. Just one more further reminder that we are a 501c3 nonprofit. And if you enjoyed this program and you'd like to help us to support programs like this and others, we'd appreciate a donation. Otherwise, have a wonderful evening and have a great day.